Hello, everyone. My name is Matthew Meyers. I'm a PGY3 at Vanderbilt University Medical Center. I'm presenting today on behalf of my colleagues Amanda Morrison, Mohammed Hyatt, and Kevin Buell. We present a case today entitled Pseudocyst Causing Obstruction, a rare complication of acute pancreatitis. So without further ado, let's jump right into the case. We had a 65-year-old woman with a past family history statement for alcohol use disorder and pancreatitis previously, presented to our emergency department with a chief complaint of altered mental status. The history of presentation was severely limited due to her profound alteration. Per EMS, the patient was found down, surrounded by bloody emesis. In reviewing her previous admissions, she appeared to have had an episode of acute pancreatitis approximately 2 months prior to this hospitalization, but she had not been seen since by any of our providers. On arrival, her vitals were notable for a heart rate of 115, blood pressure of 122/76, a respiratory rate of 24, and O2 saturations of 100% on room air. On her physical examination, she was ill-appearing. She was unable to follow commands, but she was protecting her airway. She was alert but not oriented. Her cranial nerves were intact. She moved all extremities spontaneously. She had no scleral icterus. Her mucous membranes were noted to be dry. And her abdomen was noted to be distended with decreased bowel sounds. She had an NG tube placed, and she immediately had 1 liter of dark output when that was placed to suction. In terms of other objective data, her labs were notable for a white count of 14.3, a bicarbonate of 47, creatinine of 9.09, from a baseline of what was thought to be 1.1 at her last admission, an anion gap of 35, an ABG with a pH of 7.59, a carbon dioxide of 64, oxygen of 85, and bicarbonate of 61. She had a urine chloride less than 20. In terms of imaging, she had a CT scan of her abdomen and pelvis without contrast that showed a very large 16.3 by 11.8 centimeter hypodense fluid collection in continuity with the pancreatic tail. Looking at the same study from a sagittal view, she had what likely represented a small bowel obstruction with a transition point in the central abdomen, which you can see in the top right corner. Diagnosis. Ultimately, the patient was diagnosed with a small bowel obstruction secondary to a pseudocyst mass effect. Her significant chloride-responsive metabolic alkalosis was attributed to her vomiting, which was secondary to her obstruction. Her anion gap metabolic acidosis was secondary to her renal insufficiency, which was likely pre-renal in etiology due to her vomiting history. She was treated with intravenous normal saline, and her acid-base disturbances and acute kidney injury slowly resolved. Interventional radiology was also consulted, and they performed percutaneous drainage of the pseudocyst with 2 liters removed and a drain that was left in sight for 48 hours. Over the course of her hospitalization, her mental status slowly improved, and she began to tolerate by-mouth nutrition. She was discharged and had follow-up with our GI clinic 8 weeks later, and imaging showed complete resolution of her pseudocyst. In conclusion, we have a very interesting case of a very large pseudocyst causing a small bowel obstruction, which is a rare complication of acute pancreatitis. We know that pseudocysts in general are common after acute pancreatitis, occurring in up to 20% of cases. But this small bowel obstruction after a pseudocyst is very rare and only reported in case reports when looking into the literature. Pseudocysts in general usually appear approximately 4 weeks after pancreatitis, and they usually resolve spontaneously on their own. However, there is intervention required in certain situations, and these include pseudocysts that are symptomatic, rapidly expanding, or pseudocysts causing systemic illness, which certainly in our patient's case, that was what had occurred. Therefore, it made sense to drain her pseudocysts, which led to complete resolution of her symptoms. In conclusion, we present a very interesting case of a pseudocyst causing small bowel obstruction. We hope this has been helpful to you and an interesting case for you to learn about. And we hope that you enjoy the rest of today's presentations. Thank you very much and have a great day.